Okay. Good afternoon, everyone. I know I'm expecting a couple more people, but seems like some people are running a bit late. So it's another empowerment session with IBS. And today we're having our good friend, IBS friend and member, Dr. McMillan. But before we get it, before we do the introductions and stuff, there are just a couple of things I want to just mention that well, I guess everyone here is familiar with IBS, and really give God thanks that we can be doing some of these empowerment sessions that really help us to move forward. And I do want to acknowledge that Sonia mentioned that from the last session, she really benefited quite a bit. And probably we should just, we should use it as a testimonial from Sonia. But before Sonia does that, I just ask Rachel. Rachel, you're on. Is Rachel on?
Yes, I'm on.
Okay. Are you? You're on. Okay. Your video isn't on. Okay.
Oh,
Rachel,
let me turn on the video. Sorry about that.
Yeah. So I just wanted Rachel to share, as we mentioned, we're really committed as a group from IBS to really with these empowerment sessions, but we're also committed to, oh, sorry, I'm trying to organize things. Yeah, we're also committed as a group to really, reach out to the community, build, and, even through these empowerment sessions and even through giving. And Rachel, you wanted to share something that's coming up in December, IBS?
Yes, thank you, Auntie Ruth. So I just wanted to announce that on December the 11th, IBS will be hosting its second annual Christmas charity event at 7 p.m. Eastern Time. So last year we held the same event. We had a wonderful turnout, and we were able to fundraise a significant funds for quite a few initiatives. For example, the Bible Distribution Initiative in Malawi. And in fact, one of our members or occasional members, Pastor Thomas, he was one of the pastors who led in terms of distributing those funds in Malawi so that people could get the Bibles. Spreading the gospel there is very important because Islam is the second largest religion there, and we all know that Islam is disseminating, at quite a rapid pace throughout Africa and the Middle East. So we want to make sure that the gospel of Jesus Christ remains prioritized. Last year, we were also able to give to 3 blind women located in Jamaica. So this year, we plan on continuing to support those initiatives. We want to continue raising funds for the Bible distribution in Malawi. We want to continue supporting those 3 blind women in Jamaica. And we plan on supporting a new initiative as well, which is raising funds for blood pressure machines in Jamaica at the Bustamante Children's Hospital. So that's an important thing as well that we want to focus on. So we definitely need your help to execute all these initiatives, and the Christmas charity will be the perfect time for you to give. We'll have several guest performances planned, experienced singers, dancers, writers coming to show their talents in praise and thanksgiving of the Lord. So we will provide a link during the event for you to contribute. And if you are not able to attend the event or you'd like to give in advance of the event, a link will also be provided for the opportunity to contribute. Just reach out to Ruth Brown via the WhatsApp chat or via email if you have her email. If you'd like to give in advance. And if you don't have her contact information, please let us know in the chat, in the Zoom chat, so that we can reach out to you and give you that information. So once again, that's December the 11th, only 3 weeks away at 7 p.m. Eastern Time. Don't miss it. We want to see you there.
Thank you, Rachel. Thanks. And, it's very, we cover hypertension today, and that's going to be that's very relevant as we look at getting some blood pressure machines for the Bustamante Hospital. So now we're getting into our main presentation, and we'll have the presentation by Dr. McMillan as we normally do, and then then we'll have a time of question and answers. And I'm going to ask Lily just to do the introduction for us.
Yes, I'd like to say good afternoon to everyone, and welcome all to our IBS Empowerment event on hypertension. We encourage you to come and listen, and to the expert medical doctor, Dr. McMillan, which we're so proud to have here today. Dr. Philip McMillan is a consultant physician in the NHS UK. Dr. McMillan is also an interventional keynote speaker on dementia, having presented at conferences in Singapore, Japan, Italy and Ireland, UK, Canada, and China. And he most recently proposed a breakthrough theory on pathology of dementia and has developed deep insights into the brain function. This is not what he's talking about today, but there are honorable mentions that I wanted to mention that, so that for those who have not had the opportunity to meet him, you're going to be in for a great treat today, because he will be speaking on hypertension, and we may have an opportunity to ask him a couple of questions and get some answers. Unfortunately, this is something that has impacted a lot of people. If it's not yourself, it could be someone you know. So it's going to be a very informative event, and we thank Dr. McMillan for coming out and doing this for us. Thank you.
Okay, thanks, Lily, who is one of the co-leaders for the empowerment event. So thanks a lot, Lily, for that. And now we pass on to Dr. McMillan.
Oh, thank you very much, Ruth and Lily. And yeah, I'm glad to share some ideas here. This is something that I talk to patients about every day. I'm on call this weekend, so as again seeing patients, and blood pressure management is a critical part of what we do all the time in terms of our work, certainly in hospitals, and I think in terms of GP practices. So when I thought about doing the presentation, truthfully, time was a factor. And so what I did was that I adapted this presentation from a professor, Dr. Usman, in India. And I found this was a really good summary. I've done a few tweaks to it, but I thought that overall it was quite relevant. And I thought I'd run through it and then highlight a few questions, and importantly, show you what I think is the template for you to use when you think of high blood pressure and hypertension. So essentially what we'll do is just run through some of those points. So let me just switch over to this, and I'll go in the background. So as I said, hypertension is defined as systolic blood pressure of greater than 140 millimeters of mercury systolic, and diastolic of 90. The difference with regards to the diastolic and systolic, I'll try and see if I can be a bit more in the background. The difference with the diastolic and the systolic is that the systolic is a higher blood pressure. It's the one that when you have your blood pressure readings, the higher of the two numbers. And even though we say 140/90 here, it's important to remember that that is just where we define somebody as being hypertensive. And so it doesn't mean that that's the only relevant blood pressure number. So most of the cases are what we call essential hypertension. And this is the essential hypertension here, 95%, where we have no underlying cause. Secondary hypertension usually points to the fact that there are a number of causes that we can identify. And that's usually the main reason why we do a lot of the screening tests with regards to patients who are hypertensive. We do a number of tests usually initially, just to make sure they're not in the 5% who have an underlying cause that can be addressed. And even when you address the underlying cause, it doesn't mean that the problem goes away. It just means that sometimes it reduces the amount of medication that you need to use. And in terms of secondary hypertension, and I don't want to go into too much detail here because this is not a medical lecture, but just remember in the context of renal means kidney, endocrine means hormones, and other miscellaneous things like, for instance, very tight blood vessels. That's all you probably need to understand about it. And these are things we actively look for to try and identify who needs different kinds of treatment in our management of patients. So in classifying it, we have just some baseline blood pressure classification. So when you think of it, this is why I said, when you ask somebody what is a normal blood pressure, well, it should be 120/80 or less than that. Okay, so if you went to your doctor's office, that would be normal. Pre-hypertension would be between 120 to 130/80 to 89. Stage 1 hypertension is 140 to 159/90 to 99, and stage 2 hypertension is over 160/100. It's important to know that these are not fixed. And one of the things I usually encourage patients to do is if their blood pressure is elevated when they have turned up, sometimes it's just the anxiety of getting to the doctor's office, or they have white coat syndrome, and you want them, when they're relaxed, to repeat their blood pressure. Really important to know that your blood pressure literally fluctuates from second to second. So when we have blood pressure machines in the arteries, like on intensive care, if you were ever there and you looked at the blood pressure monitoring, it literally is changing all the time. And the slightest thing can cause the blood pressure to go up, and then it will come down. So a blood pressure in a specific moment is not necessarily a major deal. It's just about sustained blood pressure elevation. Now, this is some incidents from India. As I said, this was India, and truthfully, it does parallel most of the world. They found that 25% of, I guess, the city population, 10% of the rural population had hypertension. 70% of all hypertensive patients are stage 1, and 12% have isolated systolic hypertension. When we say systolic hypertension, that means that their top blood pressure is quite high and the bottom one remains about stable. So you may have somebody who has a blood pressure of 180/80, so 120/80 is a normal, with the diastolic being okay. So their diastolic is okay, but their systolic levels are quite high. It is still significant. It is better, slightly better than both being high. So it's better than 180/110, but it's still relevant because it can cause longer term organ damage in terms of disease presentation. I've got a paper here that I'm going to come to probably at the end in terms of rethinking the inclusion of race in British hypertension guidelines, because they do look at it differently based on race. This is a slide that I got with regards to the USA, where you guys are, and they've differentiated this in race, white versus black males, white females versus black females. And you can see here in the 88 to 94, there was always a prevalence where blacks were higher than whites. And that trend has continued. Now, all of the cohorts have increased the risk between 2009 to 2010. However, that's probably most significant in black males. Well, black males are here and black females are here. So what this indicates is that the risk of hypertension is higher in women who are black. Do you notice for whites, it's actually lower for women and higher for men? And this is how it is for most other conditions except hypertension. Now, truthfully, we don't quite know why that's the case, but I think it's very relevant, because what it indicates is that hypertension in Black women is a big deal, and it's something that we shouldn't ignore because it is very, very relevant in terms of their risk factors going forward. So who is at risk? advancing age, sex, men and the postmenopausal women. And this is relevant again. So it's not just women, but postmenopausal women with the higher risk. And Black women, as I said, the white women were a lower risk than men. Family history of cardiovascular disease or hypertension, a relatively sedentary life or psychosocial stress, smoking, your diet, low fruit consumption, obesity and weight gain, and then other comorbidities like diabetes and high cholesterol, and then, of course, high intake of alcohol. And one of the conversations that usually comes up is that you need to let people try and deal with some of the lifestyle issues before you start using medication. But that can be quite difficult for some patients, and some patients don't want to adjust their lifestyle issues, and they want to continue their lifestyle and therefore just use medication. I don't argue with patients on that. At the end of the day, if somebody's not going to change their lifestyle, I'd rather them be upfront, and then we can say, okay, well, what else are you going to fix? You may not want to fix your diet, but does that mean you're going to exercise more? Or you may not want to exercise, but does that mean you're going to fix your diet? It's that kind of conversation. Everything is about a negotiation between the patient and the clinician. Why to treat? Why do we treat patients with elevated blood pressure? Well, it's because it has risks. Okay. The way to think about high blood pressure is literally to think about it. I have found this analogy in my mind helps, is just imagine that in your house, you have a water pump to increase the pressure in your shower, okay? That water pump can put the pressure in the tubing going to the showers and everywhere else in the house very high. The point is that if the machine, if that pump is working all the time and putting pressure on the pipes, will there be an increased risk of a pipe bursting in the house, or it causing damage to the pipes or damage to the shower or even damage to the pump itself? And that's essentially how I would look at hypertension. Your blood pressure needs to be at a certain level to move blood around your body. But if it goes quite high, then starts to damage the organs in the body. And you can see here, the heart gets bigger. That's left ventricular hypertrophy because it has to pump harder against the blood pressure. That puts people at risk of heart attacks, coronary artery disease, because again, another important issue is that as the pressure in the blood vessels increase, your blood vessels are kind of like glass on the inside. They're perfectly smooth. And the higher the blood pressure, you may find that it creates little bits of damage, and then that's what increases the risk of plaque forming in the arteries. Then there are things like hypertensive encephalopathy. That's rare, so don't worry about that. But certainly bleeds on the brain and strokes, preeclampsia in pregnancy, kidney disease. That's a big one, causes long-term damage to the kidney. It has impact on the eyes, so leading to blindness. Aortic aneurysm, just like this is a weakness in the blood vessels, the major blood vessel in the aorta going down from the heart down to the legs and so on. And this can get quite large and rupture. It's a very serious condition. Again, not as common, but very important. Gangrene, that's usually through peripheral vascular disease. So again, everything is about damaging the blood vessels. And then as they become damaged because of the high pressures in the arteries, every little dent in it then gets filled with plaque, and that plaque then gets bigger over time, and it eventually damages the blood flow, and that blood flow will get blocked. Additionally, the plaques can get torn off. And when I say plaques, I'm trying to think of people don't necessarily understand what I mean. How would I describe a plaque? If you well, a plaque would be the equivalent of, if you think about your kettle, the scaling that's inside your kettle is probably a good example of what would happen with plaque. The deposits of calcium and so on in the kettle that you have to clean out from time to time is kind of like what happens in the arteries, and it increases over time with high blood pressure and certain other conditions. So by reducing the blood pressure, you reduce the speed that this is occurring. So it doesn't mean that it will not occur, but it occurs at a lower frequency. And again, here, this is the target organ damage. And again, it's talking about the heart. Again, that's a big one. Heart attacks are a significant outcome with regards to hypertension, strokes. This is what I see all the time. Kidney disease, peripheral vascular disease, and eye disease, retinopathy. Retinopathy is one that I don't think you should underestimate. We can see it in the blood vessels in the eye. It's one of the only places that we can see what's happening to blood vessels around the body. And when you think about what you see in the eye, with they have these protein exudates, they have tortuous, very tight blood vessels that you can see in the eye. And you have to imagine that this is what is happening all through the body, including in the brain. And that is what is significant long-term with hypertension. And the risk of blood pressure relationship to not to cerebrovascular disease, but also cardiometabolic disease is quite consistent and independent of other risk factors. Pre-hypertension signals, we need to educate patients so that when they are seeing the pre-hypertension, that means 120 to 130 over 80 to 90, those are signals that you shouldn't ignore. And that's primarily what I'm getting at here, is that I am trying to raise the awareness, not just if you already have hypertension, but especially if you are a Black woman, how to look out for it to minimize the longer term risk. I describe hypertension as a pension plan. The benefits of managing blood pressure, it tends to last 5 to 10 years. And so it almost becomes a pension investment. It's kind of like small increments of work presently will reduce that 10-year risk. So instead of having an event at 60, it may occur at 70 or 75. And that's worth it, believe me, in terms of pension, in terms of your health pension. So that's the way to look at managing hypertension. Diagnosis of it, again, it's really, oftentimes patients don't know. It's a silent killer. Some people have headaches, some people have dizziness and fatigue, and then in very severe hypertension, you can have nosebleeds and so on. But listen, here is the serious thing about hypertension. You don't know. If you haven't measured your blood pressure, very often you will have no idea because there are no symptoms. Most of the diagnosis of hypertension is purely incidental. And this is when patients turn up either to hospital or in the doctor's office and they have their blood pressure checked. This is why we do it, because oftentimes you wouldn't know if you didn't do a routine measure of the blood pressure. And this is an important part we call self-measurement of blood pressure. Now, this is a biggie. This is something that I do all the time with my patients. And it's a discussion that I'm going to have probably towards the end when I show you what what I've built just for you all today, but I'll give it to my patients as well. But I really like self-management of blood pressure. And I'll come back to this in a little bit because I think it's extremely important and probably the most valuable takeaway that I want you to get today. How do we treat it? Again, lifestyle modification, blood pressure medication. We use an algorithm for the treatment of it, but that's for the doctor. And then there's follow-up and monitoring of blood pressure. And as we said, reduce the cardiac and renal morbidity and mortality, and trying to get the blood pressure lower, less than 130 over 80, is my target in all patients, whether or not they have diabetes or chronic kidney disease. So I understand people say 140 over 90, but I want it lower than that. And I'll explain that again when I go through that paper. Regular exercise, lose weight. I didn't do that spelling, but I should have picked it up. Reduce salt and high fats diet. We're going to come to this towards the end, and avoid harmful habits like smoking and alcohol. Again, losing weight if overweight, increasing physical activity, reducing salt, stop smoking. These are all the things that we know what we're supposed to do. And it's just that it takes time and effort. And, you know, I understand completely. I haven't been exercising myself, even though I should. And it takes some effort. You just have to recognize that it is actually important. I'm going to jump past this. And I'll just mention quickly, generally, the drugs. What you have to remember when you look at this is that we have a lot of drugs that we can use for high blood pressure, the different ways we can manage it. And this is why it's not that there's no excuse, but truthfully, we have so many options that it really doesn't take a lot if somebody's blood pressure is up and they need treatment. In the majority of cases, we can manage it. There are some people who have resistant hypertension. I'll make this full screen so you can see. And even then, I usually go to their dad to find out. You can reduce it at the brain stem. These are specific one. Good old methyl dopa is one we've used quite a lot in the past. We have ones, the alpha-1 blockers, the prazosin and so on, help with men with BPH as well, because it helps to reduce the size of the prostate. Beta blockers, very important, especially if you have heart disease. The angiotensin receptor blockers, as well as angiotensin converting enzyme inhibitors. That's an important point to highlight. For some reason, we find that ACE inhibitors are not as effective among the Black community. Doesn't mean that they don't work and you don't use them, but you tend to be a bit more selective as first line drugs with Blacks. So there's a difference between whites and Blacks in terms of which drugs we use. Sadly, when we noticed that in about 2000, I don't think there was enough research into exactly why this occurs. There are some thoughts about renin levels and so on, but it should have been more clearly delineated so that we can work out what really is going on in terms of that risk of hypertension. I'll jump past this. This is probably a little bit too much for you with regards to the medication. This is just going through different medications. And as we are saying here, causes of resistant hypertension. That means that we've got you on blood pressure medication and it's still not coming down. People taking a lot of salt in the diet. They're not taking enough diuretics, poor doses, excess alcohol intake, sometimes certain herbal supplements, over-the-counter drugs that are driving their blood pressure, or even illicit drugs, other things they may be taking. And most importantly, some people are not taking their tablets. That's probably the most common reason. Poor compliance. They find that they are having side effects. And so instead of discussing it with the doctor, they just stop taking it. That's probably one of the most common things that we see here. And as I said, hypertension is a major cause of morbidity and mortality, needs to be treated. Extremely common, very underdiagnosed and undertreated, easy to diagnose and easy to treat, and it protects the organs long-term against damage. And we have other options other than just pharmacology. Lifestyle modification should always be encouraged in all hypertensive patients. And so this is the general principles that we will be sharing about here. Now, I've made this slide here right at the end, and it's to help you to understand something that I'm interested in with regards to salt sensitivity and hypertension. And what that means is that sodium is salt, sodium chloride, and we find that some patients will take salt and their blood pressure will go up. The question is why? Why is it that children can eat all the crisps they want in the world, they can eat the peanuts with salted, and their blood pressure doesn't go up? But as people get older, they find that they are much more sensitive to the changes in sodium. So here's a simple thing. And I recently implemented it, and I was actually very surprised at how effective it was. When you look at your body, you have the extracellular space and the intracellular space. And you have to remember 66 to 70% of your body is just water. So this area here is water with some sodium in it. the extracellular space. In the intracellular space, that's inside cells, it's the majority, 2/3 of the water is actually there. So most of the water in the body is inside cells. And the major cations are potassium and magnesium. Now, what is interesting is that the research is indicating that there seems to be a chronic deficiency of magnesium. And in my mind, this is probably what makes people sensitive to sodium. Because if you don't have enough magnesium, the potassium on its own can't manage the fluid shifts. And so therefore, if you increase your sodium intake, it will pull water from inside the cells outside and push up your blood pressure. And that's what we call salt sensitivity. And this salt sensitivity can potentially be easily managed by taking magnesium. And recently, I've been applying it clinically to a few patients where, we've had them in hospital, very resistant hypertension. And I just started to give them some magnesium, just one a day. We were able to take off almost 3 of their blood pressure medications over a period of a few weeks just with doing that. It's quite remarkable. And so I'd advise anyone who is hypertensive and you don't have a secondary cause, it's quite reasonable to go to your store, your health store, and get a magnesium tablet. It doesn't matter which one, and just take a little bit of extra magnesium. Magnesium is relatively safe as long as you're not overdosing on it. And even if you were to take a lot of it, the body tends to get rid of it in urine if there is a problem. So you probably wouldn't do that if you have kidney disease or kidney failure. But for the general person, I would put this as one of the big lifestyle interventions, other than, say, reducing alcohol and so on. If you're trying to fix it, just try it for a few months to take a magnesium supplement and monitor your blood pressure. That's the summary of the presentation, but I'm going to share with you now a very important slide that we made up, and I thank Jackie helped me to put this together. And it's what I call a home blood pressure monitoring sheet. I use this all the time at in the hospital, and I explain it to patients. And because I was doing this, we put this together as something that anybody can use. And essentially, just the principle is this. Your target blood pressure is less than 130/80 when you are relaxed. This is a very important thing I explain to patients. I'm not interested in your blood pressure when you're running about or if you're stressed. I'm saying when you've got your feet up, you're looking outside at the butterflies and you're very relaxed, what is your blood pressure reading? And I tell people to do this morning and evening, and you take 3 readings each time. And that's just because your first reading tends to be a little bit higher. And what you want to do is record the lowest reading. So what you're interested in is not your highest reading, but your lowest reading. And you would then put it in your chart every day, morning and evening, 3 times, and you put in the lowest one. And you only get a tick if both numbers are less than 130/80. I'm very strict with patients. I don't accept 131/79. I don't accept 129/81. For you to get a tick, it needs to be 129/79. Then you get a tick. When your blood pressure is well controlled, you should have in a week 12 out of the 14 readings less than that. So you should be getting almost 90% ticks throughout the day. Those are my rules, and that's what I insist that the patients do. And you don't stop or you don't reduce the measurement of your blood pressure until you have consistently hit those targets. Very, very important. I cannot emphasize how important it is. And actually, when I say 130/80, I actually want your numbers to be 115/60. That's what it should be when you're relaxed. There is no value to having a high blood pressure when you're relaxed, because it tends to mirror what you are when you are asleep. And so in that sense, there is no value to having a high blood pressure when you're asleep. let the heart have a rest, let the blood vessels not be under pressure all the time. And so that's the rule that I tend to insist on that patients will do in order to maintain that blood pressure. And here are some interesting statistics. If you took two people who are 60 years old, both of them have no comorbidities. They don't have high blood pressure, diabetes, heart disease, nothing. They're 60 years old. One of them has a blood pressure of 170 as the top number, and the other one has a blood pressure of 110 as their top number. In 5 years, the person with a blood pressure of 170 has a 4 times greater risk of stroke or heart disease. 4 times. And guess what? If it was 150, it's 3 times. And even 130 is twice that of 110. That's how significant blood pressure is long-term in the management of all disease, many diseases. And I would encourage everyone, because I think most of the listeners here are probably Black and probably female. This is a biggie, and this is something that you have complete control over, and it's not difficult. And so this is probably where I'll pause. There are a few other things I could share, but I'll let people ask some questions now if they have any. So thank you very much for listening.
Okay. What we'll do then, if you want to stop sharing that, what we'll do then is we'll take, we have some questions in the chat. I'm going to ask those first, and then you can raise your hand if you have another question. So in the chat, David was asking, is magnesium aspartate okay?
What was the question?
Magnesium.
Yeah.
David, would you aspartate?
Magnesium aspartate.
Aspartate, yes.
Oh, there are whole bunches of differences with magnesium. I truthfully don't particularly care. Some of them are better absorbed than others, but it doesn't really matter too much. As long as you're getting a little bit of extra magnesium, then it should be fine.
Okay. And another question, what question from Angela? Is it okay to use blood pressure watch? Oh, the blood pressure watch.
Yeah, well, I mean, if you're doing it properly, if you just want to have an idea, yeah, you can use your watch, but wrist readings tend not to be as accurate. And so for a blood pressure machine, which is what I say to patients, is that if you're going to be doing this, we want it for the upper arm. Blood pressure machine shouldn't be the cheapest one, shouldn't be the most expensive one, just a routine one that you can consistently measure your blood pressure. If you've had it for a long time and haven't had it calibrated, it would probably be wise to get a new one.
Okay. And how do you know if you need to get a new blood pressure machine? I mean, because sometimes you're not even sure if the readings are correct.
Yeah, usually in the pack, there will be something that tells you about calibration. And maybe sometimes the best way to calibrate it is to take it with you when you go to the doctor. Say, let them use their machine, then you use yours, and you should be able to see a parallel in terms of the readings. It won't be exact, but it should be relatively close.
Okay. And another question, just before I go to another one on the chat. We talk about the salt. You're talking about salt insensitivity, right? There is also this notion about the minerals that you get in salt, and that your body does need good salt, like the Himalaya salt. So I had stopped using salt, and then I realized that you do need salt with the minerals. So I use a Himalaya salt.
I have no idea what is Himalaya salt. When you say the minerals, what are you talking about?
Well, they said that, the table salt, they strip all the minerals from the table salt. But when you use like the sea salt or the Himalaya salt, that is a better salt for your body.
Well, it depends on what you're trying to do. So yes, there are a number of trace elements that may be in these salts that your body will need. Yeah, but if you need low salt, then you're better off just reducing the salt and taking these as an extra supplement, because you'll find that in most multivitamins, they'll have all of the chromium, the manganese, all these other things that your body needs. And I think that's probably what they're talking about. But if you need to reduce your salt, I wouldn't take extra Himalayan salt as a better option. I think that at the end of the day, if you are salt sensitive, you have to just reduce the amount of sodium. And it's important to remember that it's not just salt, it's sodium. So when you look carefully at what you're drinking, say, for instance, a lot of drinks that you have that are sweetened, they tend to be balanced with sodium something or another. You're still having a lot of sodium. And so sometimes patients will think that they've cut out the crisps, and then they're drinking some other kind of drink that has high levels of sodium. So say, for instance, I think Lucozade is a good example, high levels of sodium. And so you don't realize you're taking it in other forms. So it's not about the salt per se, it's about reducing your sodium intake.
Intake, okay. That's very, very good to know. Okay, so Dorothy has asked, how much alcohol and caffeine is safe to consume per day?
I think Dorothy is drinking too much.
No, Philip. Seriously, you know, should we cut out tea? Should we cut out coffee? Or is it okay to have
I'm just joking. Yeah.
I know.
So what I'm saying is that at the end of the day, we usually recommend in the UK 10 units per week. And it's about equal for men and women these days. But it's not actually about how much alcohol you need. So I'll give you an example. I'll break it down here. Everybody must have been going out to a wedding or something, and everybody's drinking. You will notice there's some people who can drink 10 glasses of wine and they're not even tipsy. And then somebody else drinks 2 glasses and they're tipsy, okay? And that's just about the ability of the body to break down alcohol, usually in the gut, before it's absorbed. It's alcohol dehydrogenase. The Chinese don't have any. So this is why Chinese tend to get flushed as soon as they drink something. So the question is not actually just about how much alcohol you should drink as a general rule. You also need to be aware of what are your limits in terms of alcohol intake. You know, are you somebody who can take high amounts? Even then, we'd still recommend 10 units. That's probably about in a week. It depends on how big your glasses are, but a small glass of wine would be about 1 to 2 units. So it's you know, maybe 1 glass 5 days a week of red wine or something like that. But the 10 units is the basis that we tend to work from. But I usually encourage people just to be aware that not everybody is the same. You must know what your body can tolerate.
Okay.
Does that also apply to the caffeine, like the tea and the coffee?
A simple principle that, again, I've observed in patients. There is absolutely nothing that anything can do you damage if it's not done in moderation. Okay? And so if you are drinking excessive amounts of tea or coffee, it's going to cause you problems. And so there are 2 principles to this. 1, moderate what you're taking. And 2, regularly do a fast from it, where you stop taking it for maybe a week, and then you go back to doing it and you moderate it. And that's because you just never quite know what impact that thing that you're taking. And sometimes it's not just about the caffeine, it can sometimes be the brand. And it's really unique between people. So one person can be using it and they have no problems, but you use it and it creates a whole bunch of problems. So this is why I said that it's more than just being aware of volume, but being sensitive to what it is that your body tolerates easily.
Okay, thanks.
Thanks a lot. And Sonia, is Sonia here? Sonia?
Yes.
Wanted to share? Yes, can go ahead, Sonia.
I wanted to tell you, thank you, Dr. McMillan, because the last time we spoke, I was the person who knew my blood pressure and you told me about the magnesium, and I did go and get the magnesium, and I have been taking my blood pressure more often. I never did it in the evening. I just did it in the morning, but I wrote them down and I showed them to my doctor, and I was on amlodipine and hydrochlorothiazide, and she took me off the hydrochlorothiazide, and she told me if I continued with these numbers, I have an appointment with her in December. She will reduce my amlodipine, and if I keep up the good work, she says, I can eventually come off of the medication.
Absolutely.
So the magnesium does work. It did make a difference for me. And I also added exercise.
Yes, absolutely.
Right.
Yes. So this is the thing, and that's your pension, you know, Sonia. You are investing long term, and you will find that the way it works in medicine is that it's not that we are never going to have a problem. What happens is that when you do that, even if you have a problem, it will be less significant than it could have been, and it will take longer.
Right. And I also want to say, as a side effect of just watching my diet and watching what I'm doing, I actually lost 30 pounds.
Wow.
And I took off, and I was on glyburide and metformin. I got taken off glyburide, but I was introduced to something new, Ozempic, which I was wondering what your opinion is on it, because it works very well with me. My A1C is at 6 point something. After
which drug is that one?
Ozempic.
Yeah, you have to spell it, because in the US there'll be different phrases.
Ozempic.
Okay.
What is that for? What is that for?
It's for my
Okay.
A1C for diabetes.
Yes, yeah. Here what, you know, I understand why they're doing, and that will have an impact on your weight loss. How do I say? You're taking the magnesium. I'm trying to think carefully how to say something to you, because you look as though you will continue to work at these things. What I'd say to you is that if you want to step it up a little bit, okay? This advice, because how much more weight do you have to lose?
I would say another 50 pounds.
50 pounds. Okay.
Yeah.
What you're going to do, just follow this advice.
Okay.
And you're not allowed to ask why. You just have
okay.
Okay. All right. So I want you, when you're exercising, whether or not you're walking, riding a cycle or anything, is to do it in a sweatsuit.
Okay.
Do it in a sweatsuit. Get a proper one from Amazon, or if you don't have one, use a garbage bag over. You can just cut out arms and a neck and put it over a
I do have a sweatsuit.
So do a sweatsuit. And I want your aim when you exercise is to be covered in sweat. Okay? At the end of it. And then you must drink. I don't know which ones in the US, but I want you to drink either Volvic, Spritzer, or Fiji water.
Okay, Fiji water. I like that one.
Yeah. So Fiji water, 2 liters every time, and just be covered in sweat 5 days a week.
Okay.
And I have a feeling that not only will your weight melt away after about 6 months, but you may find that your diabetes disappears as well.
Wow. I will try that. Thank you very much.
Well,
I will follow that advice.
Dr. McMillan, probably there are other persons, you know, including me, who want to take off a couple pounds, COVID pounds, you know.
Yes.
So was this something that I could also do? I mean,
yes. What people underestimate is the sweat glands. You have to remember that your sweat glands are equivalent on your skin. There are 2 million of them. And it's equivalent to what you have in both kidneys. And so in effect on your skin, you have 2 extra kidneys. And so by sweating, the beauty about the sweat glands is that they get rid of different things than the kidneys. And there's some very specific work that it will be doing that I think is very significant for long-term health generally. And so, yes, it's the same advice for anyone. If you're going to exercise, try and use those sweat glands.
So, and then the water that you mentioned, I think people would want to get that, understand
Yes.
what it is.
I'm not telling you why. It's
I understand, but you mentioned, I think if you could spell this out for us, the
Oh,
name of the water.
Fiji. Don't you know Fiji water, Fiji?
Fij, but you mentioned some other ones.
Spritzer. Spritzer is another brand. And Volvic. You must know Volvic water.
I'm not familiar. What about coconut water?
No, not for what I'm talking about. Coconut water is good generally, but for what I'm talking about, it's one of those 3.
Okay. Wow, we're getting, we really, you really give us such great information every time. You go way beyond, somebody asked, I think Lily was asking, how much exercise?
Yeah, well, the rules are, again, it depends on what you're doing, where you are. And here's an interesting thing, actually. I'm going to say something to you. These are some of the ideas I've come up with over the years. I'm sharing some of those thoughts with you. When we think of exercise, there's an interesting pattern. Exercise, so if you do high intensity workouts and so on, and you're running about, it's remarkably not much more beneficial than just walking or things like yoga, okay? And it raises a question as to, therefore, what really is the value of the high intensity exercise? That's where the weight loss comes in. But outside of weight loss, there's a very simple thing that all 3 of these forms of exercise have, and that's deep breathing. Okay, I think we underestimate how valuable deep breathing is. And it's simple. 4 breaths in, or depending on how you do it, 8 breaths in, 8 breaths out. 8 breaths in, 8 breaths out. What you're doing is you're doing a complete clear of your lungs, because when you're breathing normally, your lungs have about 2.6 liters. And you're breathing normally, you're only moving about 600. The rest of it is just kind of sitting there. And I think we underestimate the importance of breathing in terms of even the lungs as an excretory organ and the health benefit of just clearing your lungs. Twice a day, I would say, in the morning, do it 10 times, 8 breaths in, 8 breaths out, do it in the evening, 8 breaths in, 8 breaths out, and you do that regularly. And I think you would be surprised how many health benefits come from just that one action. So when you talk about exercise, what I would say is be focused on what it is you're doing. So if you are for weight loss, then yes, you probably need to do more high intensity exercise, and you need to focus on, as I say, the sweating. If it's more general, then I would say even a lower intensity exercise, walking, or yoga or swimming could still be extremely valuable and probably just as beneficial and protect your knees. So it depends on each person's interest, capacity, and comorbidity.
Okay. If you remember to raise your hand if you have a question. So with were two things I wanted to ask about the fat reduction, because there is the whole train of thought that for a while this whole thing about reducing fat and the negative impact of reducing fat in the diet. We should have more, we should be encouraging a bit more fat and less carbohydrates.
No, I think that we have to break this out. As you remember, there were times when butter was bad for you and eggs were bad for you. Now it's good for you. That kind of thing. I think that this is a commercial play. They're playing around with people. The real issue in terms of health is a high fructose corn syrup. Or let me clarify it. Let me break it down a bit further.
Yes.
Sugar, not cane sugar, but what they call sugar and sweeteners in food. Just think about something here. You have to know what the history is.
Yes.
In the 1960s, they found high fructose, HFCS, corn syrup. And what this was that they found that they could take the sugar from corn and then split it into glucose and fructose, okay? Normal sugar, sucrose, is glucose and fructose, two separate sugar molecules stuck together, all right? Your body can't absorb sucrose. It needs a special enzyme to cut it in the intestine, and then it can absorb it, all right? What it means is when they split it, and then they mixed it 50-50, the glucose and the fructose, they called it sugar. It's not sugar, because sugar is sucrose. But this is pure glucose and pure fructose. That's what you are ingesting most of the time. And in reality, any product that can last for more than 8 months on a shelf cannot have sucrose in it. That's why it was so important, because it meant we can have things that could last for 4 or 5 years without expiring. Because when you use fructose and glucose, not only is it sweeter, but it has a longer shelf life.
Oh, okay.
So what we are ingesting is not sugar. It is pure fructose and pure glucose. And believe me, the long-term health impact on that is humongous. That's what is doing the damage. Don't worry so much about fat. Just think very carefully as to everything you're taking in that is sweet. If it's not brown sugar, be careful.
Oh. But what were you going to say about the fat?
I just say that the reason why I'm cautious about saying anything about fat,
Right,
is because one of the very useful strategies that depends on the specific health needs of a person is a ketogenic diet. That's where it's high fat, high protein, no carbs.
right.
And so that's also a useful diet, but not long-term. You can use it in weight loss. It really can improve the function of the body, but it has longer-term risks. And so it means therefore that fat in itself is not necessarily a bad thing. And this is what I'm saying, is that the thing that we are mixing up is we are thinking that it is the fat that is making us overweight. It's the sugar, because when you take in high levels of fructose, and fructose is what you normally get in fruit. So fruit normally have fructose in it, but the amount of fructose you have in an apple is going to be a fraction of what you have in a Mars bar. The problem with fructose is that the only conversion the body can do with it is turn it into fat.
Okay.
That's what's driving the weight. This is what I'm saying, is that people think it's the high fat that's doing it. No, it's not that, it's the fructose.
Wow. You know, that should be something that they really share a lot in the, you know, because of all this processed food.
No, it's not. The commercial people are playing around,
Yeah,
and they don't want you to be aware of that, because it will have an impact
and
on.
we should really ensure that our children are not being exposed to a lot of this, because it is really destructive, and they become hooked.
Oh yeah, I can tell you that a lot of children who have ADHD, you just need to take the sweeteners out of their diet. They'll be fine.
Philip, could you
Charlie?
can you comment on diet soda?
Sorry.
Oh God, please. Listen, there's no such thing as a diet soda. It just means, as I say to people, is that if you drink a diet soda, is it sweet? Is it sweet?
Yes, it is sweet.
Yeah, okay. But it doesn't have sugar in it. So they tell you it's diet because it's sweet and it doesn't have sugar. Let me tell you what happens. So you then have a diet soda. It's sweet. So guess what? your body immediately starts secreting insulin in anticipation for the carbohydrate load. There are lots of other hormones that immediately kick in because they know that within 10 to 15 minutes, there's going to be a surge of glucose in the bloodstream. So the body gets pre-prepared. But guess what? You drink it and there is nothing. But the glucose is still the insulin is still working. So it starts to push down your blood glucose levels. What do? There's a signal that tells you, oh my goodness, your blood glucose levels are going too low. You need to eat something. And so what you find is that you eat more. It is not that. You still have to deal with the high insulin that you've driven from the taste of the diet soda. There are no tricks in medicine. There is nothing you can do to trick the body. It will do harm in one way or the other. You're either drinking water or you're drinking something that is going to, in the long term, there's no harm with drinking a diet soda every once in a while, but please don't drink it thinking that it's actually going to make you lose weight.
Oh my God. Okay, let's have Charlene. You've raised your hand and then there's another question in the chat after. Charlene, you want to go ahead?
Hi, Dr. McMillan. So one of the things that I heard the advice you gave Sonia on water, on drinking. The reason I'm asking the question is one of the challenges I've been running into is when they draw my blood, I am dehydrated. So I have to increase my water intake. Now, using the direction you gave on the exercise, how much more water for somebody who's dehydrated would have to drink? Because to me, I've been losing a lot of water through sweat.
Okay, so you are already sweating.
But but using a plastic bag, because I've experienced that. That is water you're using.
Yeah. So the first question you'd have to ask Charlene is, why are you dehydrated?
It's my water intake. It's low.
You what?
My water intake. They told me that because yeah.
So it's not that you are dehydrated, it's that you're not drinking enough water.
Well, they did some blood work and it pointed out that I was dehydrated.
I know. I'm saying that it's not because there is a problem with you. You just don't like water. And so you're not drinking 2 to 3 liters a day of water, are you?
No.
That's right. And so literally in 24 hours, you can sort out your dehydration. Just drink 4 liters of water. You won't be dehydrated.
And then, so to follow the exercise routine that you gave Sonia, will that create a problem? That's what I'm concerned about. No,
you just drink more water. So here's an interesting thing.
Then 5 liters of water. That's a whole lot of water.
I know, but that's what I'm saying is that the problem is not the dehydration. It's just that you're not drinking enough water. Here's an interesting thing. What we've found is that a lot of people, including myself, don't drink enough water. It is really one of the most simple things you can do. 2 glasses in the morning as soon as you wake up, a glass before every meal, so before lunch, before supper, and then 2 more glasses in the evening. That's still about 6, and you need a few more thrown in otherwise. One of the problems that many people have is that because they're not drinking any water, your body has lost the ability to differentiate between thirst and hunger.
Yeah.
And so then what happens is that many times you feel hungry, but it's not because you're hungry, it's because you're thirsty. And so you eat because that's the only way that the body can get fluid. And so you eat more. So a lot of the problem is so if you just drank more, you would find that you eat less. This is why do you think the restaurants give you water when you go? They know this. They know that if you drink a glass of water before you eat, you are not going to be as hungry. That's why they do it. They know this. This is what I'm saying. This is stuff that we know and is being used all around us, but we are not applying. And so it's just to drink more water. In your case, you just need to drink more. Just get used to the taste of it.
Okay. And we have here Pastor Brian asking, explain the difference between saturated and
Oh, dear.
polyunsaturated.
I won't try because I can't even remember myself, and that in itself is probably, again, I say to you that outside of the fact that there are certain fats that we use, especially with the way that we cook food, that the body struggles to break down and it creates bad fats. But here's something important. The more we're looking at the way how the body works, the fat is a distraction. That's why I told you about the sugar. The fat is a distraction. It's not that there are some fats that are not bad for you. But again, if you're not having high quantities of it, and if you're having good fats on a regular basis, the olive oil and so on, there isn't much of a problem. Where we have most of our issue is in regards to the amount and the kind of sugar that we're taking in. That's the principle that I would say. Most people know a healthy diet if they actually think about it. It's not complicated. You're not eating McDonald's every other day. That's going to have high levels of unsaturated fats, and that's not going to be very good. But there is no harm with eating a McDonald's every once in a while. It's good to give your body a little bit of stretch. You know, it's not that you want to be perfect all the time. And so the issue is usually the things that we're doing very consistently that are doing the damage.
Oh, that's so wonderful to hear. Let's take Judy's question and then we go to May. Judy, could you tell us about carbonated water, Perrier water? Example, Perrier water.
Well, I don't know much about carbonated water, but why are you drinking it?
Judith?
Primarily because it tastes better, and trying to cut out the sodas, the Diet Coke. For the
So what
Coke.
happened to good old water, tap water, still water?
It doesn't taste as nice. I mean, just having that little pep in the water.
And all I'm saying is that the principle, I'll give you an example. Because I've learned to quiz patients. A patient once was in clinic with headaches. She'd been having headaches for years. It was a bit of a struggle. She ended up getting all the scans done. There was nothing there. And so you're reassuring her about it. And then you say, well, she says, what's the cause of it? We don't know. So then I just ask patients about their diet. And I say, what are you drinking? And she says, water. And so I've learned from experience that you don't leave it at that. When you say, somebody says water, you ask them, what exactly are you drinking when you say water? She was drinking tonic water, 2 liters a day. And I thought, really? Why would you drink tonic water? I mean, who drinks 2 liters of tonic water a day? And that's the kind of thing. So I encourage us to remain simple in our diet. There is nothing wrong with some carbonated water, but the mere fact that it is carbonated and it's likely to have some preservative or another in it, I would say that that's more of a than a regular ingestion. Just drink plain water.
Okay. May, you can unmute. Okay. May.
Hi there. Sorry about that.
Okay.
So I have a question. So I'm not a big workout person, but I do work out, and I can't imagine, unless it was life or death, for me to put on a sweat suit because I'm always hot. So can I get that same benefit, like of losing weight and just plus other benefits by just by sweating while I work out?
Yeah. The sauna works very well if you can afford it. The Norwegians and so on who do it regularly, they found a huge difference in benefit for people who regularly use the saunas. The other one that can work, it's a very simple technique, is a bath, a hot bath, where it's hot enough that you sweat in the bath. At the end of the day, it doesn't matter how you sweat. It's just
Okay.
that you sweat.
Wow. That's an easy, enjoyable way.
Yeah, it's not complex,
Oh, wow.
And then a question about water, mostly for my mom, but could apply to many people. She does not drink enough water. She's 80. And I'm just wondering, like, I know, like I tell her, you like soups, have some soup, but is there anything that you would recommend if they can't tolerate all that water?
Well, sometimes as people get older and depending on their underlying conditions, so say for instance, if they've got heart failure and they tend to retain water, though that's different, and in those cases you have to be quite specific with regards to the advice that you would give them. And so this is general advice for what I'd consider to the general healthy member of the public. In that case, though, is that it all depends on the issue with water with her. So if it's that she can't drink too much water, and as you know, in some patients, we have to restrict the amount of water they take in if they've got, say, heart failure. If it's just that she doesn't like the taste of water, this is where you just have to get creative, sometimes maybe a little bit of lime juice in it. I don't know. There's some fruits that have high water content, watermelon, that kind of thing would give you higher quantities of water. And so it's just about becoming creative. As long as you understand the principle, if you give the body the right tools to work with, it will fix itself. That's probably more, but I'm sure if people thought about it, they could come up with lots of creative solutions.
Okay, sounds fair. And thank you, Dr. McMillan. I think you should do a webinar for us every week. This is fantastic.
This is so good. Okay, one question from me. I know we're coming down to the time, but the DASH diet for they said it was
I skipped past it because I can't even remember. Let me just tell you
ASH.
Hypertension. Okay, I'll tell you in a second.
Yes.
Okay, yes, go ahead.
Yes. I actually learned about this just a couple of months ago, when I got this magazine and saw that there was the last time you spoke to us about the importance of the gut and brain connection, right?
Yeah.
I got a lot more interested in understanding about, eating the right stuff. And then I learned about this DASH diet that is built particularly for hypertension, to avoid hypertension.
Yes.
And it's recommended by doctors. I don't know why.
If you look carefully at it, it includes foods that are rich in potassium, calcium, and magnesium. Just remember the diagram that I showed you. In that diagram, it was able to, I'll put it up here. It's the sodium, magnesium. Calcium is important, but it's really the magnesium that seems to be a biggie. Most people who have hypertension, I've got some papers up here, is that the association, let me just switch over to this here, 1 second.
Yeah, it takes time.
This here is a paper that I got up here. Association of hypomagnesemia with cardiovascular disease and hypertension. So this is stuff that we are becoming more and more mainstream. And if anything, the bit that we haven't addressed properly is why are so many people hypomagnesemic. It's kind of like when we're seeing lots of people with vitamin D deficiency. We're not asking the question, why is it so common? And so I have some thoughts on that, but that's a separate thing as to why magnesium is deficient in such a significant way. But whichever way we take it, it needs to be replaced.
Okay.
Hi, Dr. McMillan. I have a friend who actually, she had very bad joint pains, and she has been taking magnesium, and it is amazing the difference it has made in her joints.
Mm-hmm.
A tremendous difference. And somebody just suggested it to her, and she's like, what? And she tried it, and it has made such a difference for her.
Yeah, it's an essential part of your body. It's just that it's intracellular more than extracellular. And again, it's just something we underestimate as being important. That's how medicine works. You realize something, if you give the body the tools, it does fix itself. It is quite a remarkable piece of kit. We have to thank God for it.
Yes, this has been amazing. May, you still have your hand up? Is there another question that you're asking, or is it that you didn't put your hand down? May? Okay, I think she probably just still has her hand up. Okay.
Ruth, I wanted to just ask if it's possible for us to get a copy of that monitoring chart.
Yeah, I think that Jackie was going to share it in the WhatsApp group.
Okay.
And so it's
Jackie?
there as a PDF.
Okay. And for the, okay, that's,
I've just shared it, so it's in the WhatsApp group now.
thank you so much. For
And I
those-
have one other question, if it's not a problem, Ruth. Dr. McMillan, on our pancreas that produces the insulin. So when we keep hearing, you have sugar, you have sugar, you have sugar, right? Is it that is it that our bodies are not producing the amount of insulin, or it's not producing enough insulin to counteract it? I'm not sure if that's the right word.
Yeah.
The amount of sugar intake that we're taking in, is that what it is? Because I mean, I keep hearing it, and I've known people who have reversed that's their bodies literally come back in line in terms of their sugar and their insulin. Is that what it is? Is that the right definition of
Yeah,
it?
so type 2 diabetes is different from type 1 diabetes. In type 1 diabetes, you don't produce enough insulin. And they're the ones who have the complications, usually the younger patients who get diabetes, and they need to be on insulin for their life. Type 2 diabetes is, however, different. In type 2 diabetes, the problem is that your body is resistant to the effect of insulin. And so therefore, as time goes by, what you find is that actually diabetes starts 5 to 10 years before you have diabetes, meaning that if you were to measure the person's insulin levels, the insulin levels would be rising to compensate for the resistance to it. When the insulin levels peak and start to fall as you burn out these islet cells in the pancreas, that's when you then start to see the symptoms of diabetes. So the issue is sometimes 5 to 10 years before, and it's because your body is resistant to the effects of insulin. So it's what we call peripheral resistance. And so this resistance is what, if you can change that, where your body becomes more sensitive to what insulin does. And primarily what insulin is doing is pushing glucose into muscle to be stored as glycogen. And that process is being inhibited in diabetes. And that is a whole different conversation. But this is why I was giving you the secret. I didn't tell you why it was going to work, but that was the secret.
Oh, okay.
We got it out of you. Ha ha ha.
So probably that would be a topic for the future, Dr. McMillan, because that's another, very problematic that many persons are dealing with as well. So
now the repair comes out.
Could you tell us what the
sorry. Did I just mute someone who was speaking? Sorry, somebody was making a comment or asking a question.
I think somebody was asking for the secret to be repeated.
No.
I will be posting this on the website. Now, if you are here and you're not a part of the WhatsApp group, or we don't have your email address, please put your information in the chat and we'll ensure that you're added. We really want to just, this has been, as usual, quite amazing in terms of Dr. McMillan coming and joining us. And we really are so grateful for this, Dr. McMillan. This has just been so amazing. And just want to ask Lily to just join Okay. Lily, just want to ask Lily just give a thanks on behalf of the group.
Yes. Hi, Dr. McMillan. I've been sitting here on the edge of my seat, and I've had a lot of aha moments and a lot of wow moments, and just amazing. Just so grateful that you came out today to give us some insight on this, and the exercising, the breathing, the magnesium, know your numbers. Like, this is just amazing that you could come out and share this with us, and we're very humbled by that, and we thank you for that. And hopefully we'll have other sessions in the future and more secrets. We'll see, right? So again, thank you very much from all of us to you, and it was fantastic. Thank you.
Thank you very much. Thank you for having me.
And thanks everyone for joining. I think we had a good group this week, this session. And Jackie in the background doing quite a bit, so really thank everyone. And have a wonderful rest of the week. And thanks again, Dr. McMillan. You've really given us a lot. We always
so much.
Even enough, but we really appreciate this.
Thank you.
Thanks for setting it up.
Thank you.
You.
Okay.
Bye. Bye, everyone.
Bye. Bye. Have a great day.
Bye, Jackie.
Take care. Bye, everyone.
Bye, everyone.
Thank you.
Jackie. Bye.
Thank
Bye.
you.
Fun. Okay, Philip. Thank you so much, Lily. It was great.
Oh, it was beautiful. I loved it.
Good. Okay.